Hi, everyone. Welcome back to Misconceptions. I am really honored to have a colleague, I guess you could say, but not really, more like somebody I've admired from afar and actually had the opportunity to meet many years ago. Welcome, Dr. Neill Epperson. Thank you so much
Hey.
for saying yes.
Yes, yes, it's always good to see you again, Deborah. And I'm thrilled. I was looking over your website and all of the different podcasts and topics, and I think this is terrific. So thank you for
Thank
having
you.
me.
Thank you. Thank you. So, what's really interesting to me, and maybe it's just because of my age and kind of being in that perimenopausal, menopausal, almost 50 age group. Yes, that's how old I am. This feeling of like, I've heard from so many women this feeling of how come nobody's talking about this and how come we were never taught anything about it? And I recently did a conversation with an OBGYN who said, like, we talked about like who are the gatekeepers of this knowledge. And I think
Yes.
about that at this middle-aged space in our lives and like who's supposed to be telling us about menopause. And we're going to focus in a little bit more specifically, though, about mental health and menopause.
Mhm.
And I'm really excited about this conversation, both personally and, of course, the professionally and putting this out into the world. So, Dr. Epperson, can you start with first telling the world about who you are and how
Sure.
come we're having this conversation?
Sure, sure. Okay. Well, Neill Epperson here. I'm chair of the Department of Psychiatry. I'm professor also at the University of Colorado Anschutz Medical Campus. I've been chair of this department, never thought I would leave the East Coast, but chair of this wonderful, like 800 plus people department for almost 7 years now. And it's great to be out here in Denver. When you and I met, I was at the University of Pennsylvania again, doing work in women's mental health and reproductive psychiatry, and something we finally call psychoneuroendocrinology.
Ooh,
Yes.
okay.
So let's
So,
break it apart. Psycho, so
please,
probably has something to do with psychiatry and mental health, neuro, brain, psycho, neuro, the neurological effects. So basically endocrinology, so the effects of hormones. So I started studying the effects of hormones on the brain when I was a fellow at Yale University many decades ago. It was in the 1990s when postpartum depression was sort of not even really being discussed very much less PMDD or premenstrual dysphoric disorder, and forget about menopause.
right.
There were very few clinician educators in this area. Reproductive psychiatry wasn't a thing. I called my first program at Yale the behavioral gynecology program because
Oh,
gynecology is actually pertains to the reproductive organs. And
right.
actually, the brain is a critical reproductive organ. And people initially said, "Oh, I think that's such a weird thing to call your program." I got a lot of flack for it. And then recently, I was with a gynecologist who said, it really is all about behavioral gynecology.
You're like, I want the credit.
I was like, that's mine. You cannot say that. So, in any case, I was at Yale for my training and then in research, as well as my clinical training as a psychiatrist for about 18 years total. And then went to the University of Pennsylvania to start their reproductive psychiatry program and continued my research. And again, I've really kind of gone all across the reproductive lifespan. Very interested, not so much just one particular part of the lifespan, which a lot of sort of reproductive psychiatrists see themselves as perinatal mental health specialists.
Very
Well,
much.
that's one way that you could think of this. But, even if you have two children, most females that have two children spend maybe 4% of their entire lifespan being pregnant and postpartum. I
Mm.
mean, 4% of their lifespan, that's just not very much time. So it's a critical time, particularly in a woman's development and obviously in survival of the species. But it is a small percentage of a woman's whole reproductive lifespan. Actually, menopause is where you spend a tremendous amount of your reproductive lifespan because even though we're living longer, but the age of menopause is still around 52 on average. So we're many of us living 3 decades after being postmenopausal. Whereas
Mm.
100 years ago, we probably died a few years after we went into menopause. So you can see why, it takes a long time for cultures to shift. It takes a long time for evolution to happen. And ultimately, I think it's one of the reasons that we don't really talk about menopause all that much, because for many decades, we weren't living that long. Now we are. So we need to get out of ourselves, our 100-year-old selves, come into
Wow.
the modern era and recognize that we're living about a third of our life in the postmenopausal state.
And recognizing also that, like, if you think about the perinatal state is one that can be a choice,
Yes,
if you're blessed with that option. And
yes.
then the menopausal state is not one that there's any choice. Like, it's coming whether you want it to or not, right? So,
Exactly.
which is just fascinating that we have so much emphasis on the perinatal versus, which you're saying is only about
Yep.
4%. I would suggest that when working within religious communities, perhaps that are having many, many more children, that the
Yes.
amount of
So
perinatal state and
good.
reproductive years are
Okay, well
quite
then let's
different.
multiply it and say five
Exactly.
children. So
Right.
maybe
Exactly.
you're living 10%
Right.
of your life in the
Yes. Yes. But
perinatal
it's
state.
really fascinating to consider the numbers when in terms
Yeah,
okay. So tell me a little bit more about psychoneuroendocrinology
yes.
and where is your research? Let's start. I'm curious, like, where's your research today? What are you
Sure,
busy with
sure.
now?
Okay,
And then let's
sure.
break it down.
Okay. Well, so it really is the study of how hormones, not just gonadal steroids. And when I say gonadal steroids, those are the ones that are produced by your ovaries if you're a female and testes if you're male. But these gonadal steroids have a profound impact on the brain and have a profound impact on like all many body tissues. I mean, there's probably no organ system in which estrogen doesn't have some impact. But when you talk about psychoneuroendocrinology, you really are focusing on the brain as your organ of interest and how these hormones, so the gonadal steroids, estradiol, and progesterone, as well as your stress hormones, cortisol, as well as other hormones like your thyroid. How do these hormones, oxytocin's another one, how do these hormones have effects on the central nervous system? And what fascinated me as a psychiatrist is how it has an impact on one's perception of oneself, the behaviors that you experience, your cognition, your mood, your appetite, your sexual interest, how you sleep, all of these things. And so that's what I've studied. I am very interested in how these hormones also affect the immune system, but mostly because immune system can also have an impact on the brain. So for me as a psychiatrist, the brain is my organ of interest and it is my primary interest. So I started out my career doing perinatal postpartum depression work, working with women with pregnancy complications, pregnancy loss, um, doing some work with postpartum OCD and those kinds of symptoms. Moved into premenstrual dysphoric disorder while I was still doing the perinatal piece. Got very interested in how these hormonal fluctuations that we experience from the time of puberty on, how they can have such a dramatic impact on your brain.
Right.
And that some women can go through these hormonal roller coasters, and that's what I call it, with this fabulously flexible female brain and not have negative mood or cognitive symptoms. And other women really have severe symptoms. And then there's a range in between. And so I went from perinatal to menopause, I mean, to PMDD and now menopause.
Wow.
And so that's sort of what I'm mostly focusing on right now is sort of an aging piece, and really thinking not only about women who undergo a natural menopause, but also women who are undergoing a surgical menopause, which
Hmm.
is, usually occurs earlier. And they often have more of the negative symptoms related to being postmenopausal because it's a very, one day you're not postmenopausal, the next day you are.
Right. Just to
That's how,
clarify what a surgical menopause is somebody has to have their ovaries
sure,
removed. Maybe they have a
exactly.
BRCA, BRCA gene, or there are other kind of
Yeah, yeah,
cancers within the body that require them to remove their ovaries. So it
exactly.
puts
Yeah,
them immediately into a hormonal state of menopause unless
yeah,
offered medication to help them kind of ride
yes.
that out. Right.
Yes, exactly, exactly. And so So again, these are all important aspects of women's health, and they're all interconnected with other parts of a woman's health. So the immune system, the stress system, her skin, for example, itchy eyes, if you talk to an ophthalmologist, if you've got, who comes in to see, God, my eyes are so itchy as a postmenopausal woman, because they're epithelial cells that line, that are part of the lining of the eye and the external lining of the eye. And estrogen has effects on
Huh.
epithelial cells on your skin. I mean, there's like so many aspects of how our bodies change, particularly as we go through menopause. And then if you do not use hormone therapy, then basically you go into like having very, very low levels of estrogen, and your body's going to react to that in some way, shape, or form. And for some people, the body changing is not particularly problematic, but for a lot of people it is. And I would say it's the majority of people that they have some problems like vasomotor symptoms, sleep difficulties, and things like that.
Where should we as women be getting some of this information? I feel like you just dropped like some, like these nuggets of gold of like, oh, if you have itchy eyes or like poor sleep issues or like psychomotor concerns. And I'm like, wait, can I write that down? Because where else should we be getting? I have never heard my OB, who I go to every year, my GYN, ever say to me, by the way, these are some of the symptoms you want to be considering as you are 48, 49, 50. Like, no one's giving us this information. And first of all,
No,
why? Why is this not
right.
being shared?
Well, one of the things that is, so I've had multiple conversations with my gynecology colleagues because they wind up referring people to me, particularly if they're having sort of cognitive issues. And I see a lot of women that start having executive functioning difficulties and verbal memory issues as they particularly undergo an acute menopause, but even with a natural menopause. And I sit and talk to these ladies, and they go, "Would you manage my menopause?" And I'm sitting here, I'm a psychiatrist, I'm
Right,
happy to
right.
prescribe your hormone therapy. I feel comfortable in that arena, but it is not the average psychiatrist that is managing the menopause. The thing is that I mean, I in a session have time to just focus on what is distressing my patient, and what their symptoms are and how they can think about managing their life, in relationship. So if you're a, traditional Jewish woman and going through and becoming postmenopausal, then not having menstruation can be a welcome event,
Sure.
but if you decided you wanted to do hormone therapy, the chances that you could have bleeding is also, and it could be unexpected. Whereas
Mm.
maybe when you were having menstrual cycles, it was at least you knew when it was going to happen. And so there's a lot of complications when you start to think about using hormone therapy in certain populations. And yet at the same time, somebody needs somebody to just sit down and talk to them about the risks and benefits of this and its potential impact on your lifestyle versus the risk and benefits of a different way to manage your symptoms. And the gynecologist doesn't really have the time to do that at least not intensively if
Right,
unless they're like a concierge or functional
right, right,
medicine doctor or
right.
that
And by
kind
the way, and it sounds to me also like they're not necessarily trained in that either, right? I mean, do they have
yeah.
complex training on menopause management?
Well, they do, and it depends. So, my dear friend Annette Santoro, who is chair of OB here, and I've talked to her about it, and she's a reproductive endocrinology and infertility specialist.
Hmm.
And so she's very much someone who, even though a lot of her job was to get people pregnant who were having
Right,
infertility,
right.
she also has a very strong interest in menopause. And so when I've queried her about this, she talks about the training that happens in OBGYN and that, it's a surgical subspecialty in a lot of ways. I mean, you have to be able to know how to do surgery, not just deliver babies naturally. You have to go through residency and know how to do C-sections and know how to do, various kinds of hysteroscopies and, other types of procedures and oophorectomies and vaginal hysterectomies.
Right.
And so you have to practice that. And one of the ways that people get really good as surgeons is by practicing that and being, having that as a focus. If you only do surgery every once in a while, you kind of lose your skills a little bit.
Right.
So depends on what field of OB you go into. So like if you're an OBGYN and you just decide to go into maternal fetal medicine, you're never dealing with menopause.
Right.
It's
Right.
the reproductive and then reproductive endocrinologists, which we call the REIs.
Right.
A lot of them focus on just the perinatal,
Just
got to get
fertility. Sure.
pregnant, get this, what have you. Your menopause is sometime later. If you're a general OBGYN, you may be still doing a lot of perinatal health, a lot of, contraception, early, family planning, things like that. So you may not spend as much time in that working with that 45 to 65-year-old patient population as much,
Hmm.
particularly not during your training. And so
Right.
they do get training in menopause. I mean, they absolutely do. But then it also what is the interest of the provider?
Right.
And and so if you've got a provider who is this is like just not their thing, um, and you've been with them since you had your babies, and
You're
maybe that's
missing. Yeah.
why
Yeah.
they
Yeah.
were
No,
great
for
when you
sure.
were, yeah, they were great at that point, but maybe
Fascinating.
this is not their wheelhouse.
Right. Okay. Yeah. So it really makes you question, like, should there be like almost like the midlife OBGYNs? So the ones that are like, and I know there are women like that here in Philly, but they're
Yes,
concierge. They're total, many of them are concierge only and private pay. And so it's really just
yes,
accessible by the wealthy. Right. Okay.
yes.
Talk to me a little bit more. I want to hear more about the, the like I guess the connection between the immunology. That was a new idea for me, that these issues of hormones would be impacted by immunology or immunology impacted. Tell me a little bit more about the connection
Sure,
there.
sure. Well, this also starts out with your stress system as well. And so, even if you took away female hormones and male sort of androgens, and yes, women also have androgens as well. But even if you took away the gonadal steroids, you have a relationship between your stress system and how frequently it's activated, particularly early in life when you're kind of your body's still developing and your brain is developing. And if you undergo a lot of childhood adversity, stress, war exposures, or poverty, all of these kinds of things, community violence, family violence, your stress system has to respond to these events. And based upon how your sort of developmental years went, the way that you respond to stress all across your lifespan can also interact with how you respond to things that trigger the inflammatory system. So typically, when you have inflammation, you want to have a stress response because you're making cortisol that helps to dampen down the inflammatory response. Like for example, if you have really bad asthma, you might be using a steroid inhaler, for example. That's like a that's sort of a synthetic version of our stress hormones.
Okay.
You're putting a steroid in your body to help to decrease the inflammation in your respiratory system. So we make these hormones naturally, these stress hormones. So there is a link between the stress hormones in your inflammatory system that ideally is healthy and is in balance. Okay. Because if you have too much of this, because your stress system is hurt, it can't really react, then you can have increase in sort of this inflammatory process that could be there just subtly across your whole life, which we know is not good for our health, is not good for cardiovascular health, brain health, what have you. Um, but now you add the female hormones in there. And there are ways in which our female hormones interact with our stress hormones and they interact with our inflammatory system. And so one of the hormones that, is called allopregnanolone, it's progesterone and it gets broken down into allopregnanolone. And as you know, you have very high levels of allopregnanolone during pregnancy and then it drops postpartum. Well, allopregnanolone is also triggered when you're in stress because it's also meant to kind of help dampen the stress response so that you don't get too much of the stress response. And so allo is good in that way, but it also has some anti-inflammatory effects as well. So estradiol has some anti-inflammatory effects. And we like those anti-inflammatory effects, particularly if your stress system is not quite working the way it should. It's nice to have a little bit of estradiol on board to help also counter your inflammatory responses to the things that are around you, the foods you eat, what have you. And so it's a very complicated system that stress, inflammation, and then you add the gonadal and neurosteroids like allopregnanolone. And so when you're trying to study all of this, it's better not to study one thing in a bubble, but to think about how just manipulating estradiol levels at menopause could have an effect, not only if you're very stressed, it could have an effect if you have high levels of inflammation. And if you have high levels of inflammation, maybe having some more estradiol might be a good thing for that person. So it is complicated. And I see your face like looking like, oh God,
I'm thinking
way too
through it. I'm thinking,
complicated.
well, the few things that I'm thinking, I mean, I'm thinking so many different levels because I also think about, I'm thinking from the fertility, right? My reproductive psychiatry brain is going, wait, first of all, allopregnanolone also is, we use that's part of the brexanolone, like,
Sure. Yes.
category of medication that's being
Yes.
used in treatment of postpartum depression. And
Yes.
then I'm also thinking about, wait a minute, when everything we talk about in terms of inflammation and immunoresponses, in terms of being like contributing factors to infertility. And yet
Yes.
I know that we're still not getting firm recommendations from ASRM of like, do this or do that in order to treat the inflammation to reduce, or increase the risk or the chance of pregnancy. Like that we're still not getting concrete, like, formal treatment recommendations that could improve pregnancy. And
Sure.
yet we know that, like you're saying, like we know there's something here that we're still trying to figure out. So my
Sure.
brain is going, where do I want to ask the next question? Are we talking about fertility or menopause? All right, let's go back to the menopause. So
Can I answer something about what you
please.
just said though?
Yeah.
I think the reason why you're still and we are still not getting like really straightforward, do this, do that, this will work, is
Yeah.
because of one of the things that I just talked about. One's early life experience has a dramatic impact on our health. I mean, it really does. I mean, and it has an impact all across the lifespan. And you can't go back and change it, but we should at least understand, is this leading to my stress response maybe not being quite as robust as it needs to be? And therefore, I am getting more inflammation than I would like to get. Maybe I need to do things that would tackle that situation, even if it's an N of one. Maybe for that person, doing more mindfulness-based stress management could potentially, because there have been studies that have shown that mindfulness, really doing the mindfulness-based stress management can help to decrease markers of inflammation. So maybe in that person, that's a really reasonable thing for them to try. Now, again, that is so precision medicine. That is like so like this is for this particular individual
Mm,
that it's one of the reasons why when you look at the masses, most of the studies out there do not look at things like early life experience. They just
right.
don't, they
Right.
can't. Even if you're looking at depression and antidepressant drugs, we know that our medications for psychosis, bipolar disorder, mood disorders, anxiety disorders work better overall in people who've not had childhood adversity or trauma. We
Mm,
just know that in general, not individually, but in general. But most of the pharmaceutical companies, when we start studying antidepressants, even brexanolone for postpartum depression, I wanted them to look at average childhood experiences because I said, I
right.
bet you those ladies will get
Do
better with
better.
this.
Oh,
But of course,
fascinating.
you can't do that in a clinical
Uh-huh.
trial. That's too
Hmm.
specific. You want to know, does this work in general for postpartum depression? And the answer was yes. I still want to do a post hoc analysis and look at that.
Yes, absolutely. Absolutely.
Yeah.
So I want to clarify one thing you said so I understand it better. When you're saying that we have an abnormal stress response when you have which causes inflammation, are you saying that
Excuse me.
the
Sorry.
Bless you, bless you. Are you saying the inflammation the stress response is not high enough or is too high when you say what is abnormal?
Well, it can be either direction. But
Okay.
what we've seen in a lot of our, and again, people have said early, okay, let's go back to several decades ago. It was like, oh, everybody thought that if you'd have been through a traumatic event, that you have a hyper stress response.
Right.
And then we've basically started to study that, it's not that simple.
Mm,
You may have a heightened stress response in the acute window. And maybe that's normal because you've undergone a traumatic event. Does that stress response sort of regulate over time? Do you go on to have post-traumatic stress disorder, which might also be a sign that your stress response did not kind of go back to baseline? And
okay. Okay.
but if you've undergone early life adversity, again, people have talked about, well, yes, you probably had multiple hits of this intense stress. After a while, your brain and the way your stress system works, the hypothalamic pituitary adrenal axis, might lead you to actually having a lower cortisol response
That's what I thought you were
when you
saying.
get
Yeah.
stressed later in life.
Right.
And so we have a tendency in the populations that I study to see a lower cortisol response later in life to when we stress them, because if they've had early life adversity. But again, if you were to look at somebody, everything's fine, they lived a pretty easygoing life, what have you, just, normal day-to-day stressors. And then something really traumatic happens, yes, you could see a high level of cortisol. Ideally, their cortisol response would go down over time, and then they would have a normal excursion with future stressors. It's just that
Mhm.
we can't underestimate the importance of the developing brain and the
Mm.
developmental windows of conception and what happens in utero to the fetus, all the way, until, young adulthood. That developmental window is just so critical.
So the cortisol response is a critical part of reducing inflammation, right?
Yes,
And so if somebody has a reduced cortisol response because they've kind of almost like desensitized to the
yes,
stressors,
yes.
then they're not producing the cortisol, which means they're not reducing the inflammation that their body probably is creating and needs to be reduced, or right, not
Right.
impacting it.
And again, some people may not have problems with heightened inflammation because they eat well. And I mean, there are plenty of studies looking at different foods that can, help you with inflammatory responses.
Hmm.
People who exercise. I mean, unfortunately, a lot of people, and especially in women, we have autoimmune diseases that are very, very common among women. And stress can activate the immune system. And so there are a lot of things that can activate the immune system as well as the stress system. You just want to balance.
Okay.
And unfortunately, when we start to look at like how do we help women feel better, there's not studies that say do this.
Uh-huh.
you
Uh-huh.
know so I try
Okay.
to look at the whole woman and I say, what's going on for my person, my patient in front of me? Are they, how are their relationships? How's their professional life? How is their physical health? How do they eat? How do they sleep? Are they, do they feel supported in their life? What was their early life experience like? How was it when they went through school? Were they bullied? Did they do well? There's just so many things that I think about when I'm sitting down with a patient. And again, I have the privilege of being able to do this as a psychiatrist. Um, but I put that into my knowledge of psychoneuroendocrinology and try to help them feel the best they possibly can within what they're willing to do.
So let's take that line of thinking when we're moving. Let's start with somebody who doesn't have significant historical or childhood trauma. I mean,
Sure.
I think everybody has something. I think, especially epigenetically, we have to
Yes.
acknowledge that, especially if you're coming from, what I've started to do in my processes with my clients is I want to know if you're the grandchildren of Holocaust survivors,
Yes. Yes.
because, and possibly at this point, really great grandchildren, because it really does. You begin to explore like how they were raised and the trauma that is absolutely inherited, and also the way that they were personally raised, like how they themselves experience their childhood is absolutely different being raised by someone who is severely traumatized. So
Yeah.
I acknowledge that there is a significant population in which I am interfacing with that has that historical trauma. And then but if we were to take somebody who had a basically normal, whatever that means, right? Let's just define normal-ish, everybody's normal light, right? Like just the people who don't have, I can't put my finger on the trauma of childhood. And we're just looking at people who've gone through their things, normal losses, normal lived experiences, whatever that looks like. And now they're hitting 43, 44, 45, and maybe you'll correct me in terms of ages. What is happening to them from a neuro or a psychoneuroendocrinological experience?
Uh-huh.
And how do we kind of begin to parse apart for ourselves what is happening internally? And then obviously I'm always about change, but like what might I address more specifically when listening to you after you've shared this experience? Like tell me a
Sure.
little bit more.
So, I mean, I always take menstrual history. I want to know, like, are you menstruating in a way that's regular to you? Are you using any exogenous hormones? And and if you're not, have there been any changes? So in your 40s to 50s, you often can start to have some subtle changes, where basically you might just notice that the flow is different, or that maybe you're just spotting, or maybe you are a day earlier or a day later, or that you're going longer, shorter. I mean, so just characteristics of the menstruation pattern is something that I want to know about. And if people are starting to see these, even if they're subtle, it means that you are moving into the perimenopause. Now, the perimenopause on average can be like about 5 years of symptoms and 5 years of kind of this, irregularity, on average. And about 80% of women will experience some kind of vasomotor symptoms, hot flashes, as we call them, or night sweats. For a good percentage of those people, they can be pretty moderate to severe. And people can also start to notice that that they don't sleep well, even if they're not having the vasomotor symptoms. Obviously, those can be linked, because if you're waking up drenched, that's going to wake you up. But a lot of women might just notice that their quality of sleep is not as good as it once was. I do see a lot of women that start to say that they don't, I mean, even though major depressive illness, a clinical depression, can occur in the perimenopause for the very first time. Women, as they go through menopause, are 2 to 3 times more likely to have their very first episode of major depressive illness, in the perimenopause. And if you've never had if you've had previous depressions, your risk of having a relapse is about 4 or 5 fold. So we know it's a risk period for clinical depression, but what I see a lot is this sense of ennui, sort of this, maybe not a full blown major depressive illness, but sort of this sense that, I just don't find pleasure in things as much as I did. I don't feel quite that, sense of vigor, and sort of engagement. And, things just, I mean, I just, instead of going out, I'll stay at home,
Hmm. Hmm. Hmm.
and I'm not particularly depressed, but I know that something's not quite right, and I don't feel like myself. I definitely will hear that as well.
Is that a dysthymia? Does it reach the levels of dysthymia, or you're not hearing it as clinically relevant
Well,
to
I mean,
that?
again, it can be, if it gets into a more severe range, then
Then it
usually it
will.
looks like
Okay.
major depressive
Right.
disorder. But again, this is more sort of a lack of interest in pleasure, slight anhedonia, slight,
Okay.
just kind of blah,
Blah. I was going to say, can we just
yes,
call it
blah.
blah? That's exactly
Yes.
the word I was going to use. Yes.
Exactly,
Okay.
exactly. And so again, what I do to help that woman, it really depends on sort of what her lifestyle factors are, what other symptoms she might be having. I often do recommend estrogen to a lot of my patients, even in the perimenopause, because their estrogen levels can be going like this. And if you give them a little bit of estrogen, then they don't bottom out as much,
Hmm.
so
Hmm.
it's more like this.
Okay.
And I do tend to pay attention to, I tend to look at hormone levels, because unlike some practices where people are being given very high levels of estrogen and testosterone, I'm trying to get more in sort of a normal physiologic range. More's not better,
Right,
So
right,
I try
right.
to keep women out of this kind of what we call supraphysiologic range. I mean, more than their physiology really needs, because,
Hmm.
we have no reason to get women up into, really high estradiol levels for extended periods of time, just to get sort of the benefit of some supplementation.
Hmm.
And when it comes to testosterone, I'm also very careful about not getting people into these, really ranges that are not, I mean, ranges that are not normal, quote unquote, normal or physiologic for a premenopausal woman.
Right, right. And so just to clarify, you're talking about two different supplementations, right? They're not a combined pill, right? Or a
No,
patch. They're
no.
really, it's two different. So you're
I
talking about
tend to,
supplementing
yeah,
two.
yes. And I
Hmm.
like to
Hmm.
supplement separately. I also, if a woman is having difficulty sleeping, if she can tolerate progesterone at night can be very helpful, because of it gets broken down into allopregnanolone, which has these GABAergic effects, so sort of settling effects. And some people find that taking progesterone at night really does help them sleep. And again, if you have a uterus, then you really need to have progesterone to protect your uterus if you're going to do, any kind of estrogen supplementation.
Tell me a little bit more so I understand that medically. Why is that?
Because basically, if you have a uterus, the uterine lining, the endometrium, which is the uterine lining, is very sensitive to the effects of estrogen.
Okay.
So if you even think about a normal menstrual cycle, one of the reasons that you have a bleeding pattern with normal menstrual cycles is that you have ovulation, the estradiol increases, it goes down a little bit, you get progesterone, estrogen stays up here a little bit, you get all of this endometrium building up. Because if you get fertilization of the egg that was released, you want to have that nice fluffy endometrium so that the egg can implant naturally and
Right.
well.
Okay.
And then you have a, fetal development, placental development. But if you don't conceive, then what is sloughing off are the cells that the estrogen stimulated,
Okay.
uh, and the building up of that endometrial lining. When you become peri and postmenopausal, you want to make sure that you're sloughing off that lining, that you don't have, if you're building it up with estrogen a lot, let's say you're a postmenopausal woman and you're taking estrogen alone, then the uterine lining can really build up, and it can, because all those cells are multiplying sort of and not being released or not being sloughed off, you get worried about endometrial hyperplasia
Hmm.
and therefore endometrial cancer.
Hmm.
And so taking the progesterone as part of hormone therapy is a way to get that to slough off. Now, some people will take estrogen daily as well as progesterone daily. And then it's kind of like you have this antagonism and you don't ever really build up that endometrium like that. Some women will say, I want to know when I'm going to bleed. So I
Hmm.
want to do estrogen alone. And then I'm going to take the progesterone for like 12 days out of the month. And
Got
then
it.
that way they can know
They
when
know
they're,
there's a period coming.
no,
Hmm.
there's
Hmm.
we call it a withdrawal bleed because
Okay.
it's not a natural period, but that's what we call it when somebody is postmenopausal. Now, if people don't want to have bleeding at all, and they are either, or they don't like progesterone, because some people, they get kind of cranky with progesterone, um, they can use a progesterone IUD, and it just emits enough progesterone all the time in the uterus that you can take estrogen and not have to worry about either taking progesterone every day or cycling. So
Okay.
that's what some women will do for their hormone therapy.
So that would
And
be like a tip. I mean, I just am most familiar with the Mirena style
yes,
IUD. That would be like a
exactly.
Mirena is producing progesterone only, and then they
Yeah,
could potentially supplement with the estrogen, but it would
yeah,
create this like kind of
yeah.
balance
A
of
balance,
hormonal
yeah.
experience.
At
Okay.
least in the uterus,
Right,
you will be
right, right,
creating a balance.
right.
And I always recommend transdermal forms of estrogen
Okay.
because of its better sort of overall safety profile, particularly
Hmm.
with liver health, your triglycerides, your cholesterol, also there's a decrease in risk for blood clots that way versus not decrease from baseline, but is less than if somebody were to take estrogen orally.
Orally. And so
Yeah,
what about for this massive number of women that I am familiar with and interacting with who have that hormonal IUD placed for many years already and they're not cycling at all? At
sure.
what point, and maybe also my understanding is it could potentially really be decreasing any kind of reactivity for the hormonal fluctuations of perimenopause or menopause. So they're not really symptomatic, maybe having some of the difficulty sleeping or maybe some of the brain fogginess I liked how you talked, what was the word you used about verbal
Uh-huh.
confusion? Like that one, right? Where I lose the words, right? So, maybe having this different symptoms that don't relate to bleeding.
Yes.
What is the recommendation only to treat symptoms, or is there wisdom in saying actually everybody is symptomatic, you just might not realize it. And we
Yeah.
should be treating with estradiol or estrogen and maybe testosterone as well, no matter what, once you reach a certain age.
Well, it's a good question, and I try to stay away from one treatment or one that we make a recommendation for everybody. Because I think that's what kind of got us in trouble with hormone therapy to begin with, that, like everybody should be on estrogen, when they're going through this period of time. And I think that we have to really think about like what are people experiencing and how can we help them within the context of their own wishes and their health, because
Hmm.
not everybody can take, hormones, and that's just the way it is. So we have to have other options for how to help them feel as healthy as they possibly can as well. And so that's been sort of my goal, is to think about like how do we manage symptoms really? Because
Hmm.
the data is suggesting that estrogen and hormone therapy is not beneficial for everybody. At
Hmm.
least I think that that's one of the reasons why we have the data that we have, that some people are like, oh, well, there's an increased risk of dementia with being on hormone therapy, or there's a decreased risk of dementia. We haven't gotten granular enough about like why might estrogen be really beneficial in this particular case or these cases, and maybe not so much in these cases. And so that's why I try to work individually and understand sort of what a woman is experiencing. I think it's always helpful if you're having lots of menopausal symptoms and there's no contraindication to taking estrogen. I think a trial of estrogen to see how much benefit you get, because we're always talking about the risks, but unless you try it, you don't know what benefit you're going to get.
Right, right,
And if
right.
you happen to be one of those people that is very sensitive to estrogen and gets a lot of benefit from it, you're going to say, well, the chances that I might have a blood clot, are very, 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 very small. It's really, I'm going to stay on it because this is great. You're going to take it
Yeah.
out of my cold, dead hand, like a lot of people say. But if you're somebody that is like, I tried it, didn't really help my mood, I'm still having brain fog. I'm still not sleeping well. I don't really have a lot of vasomotor symptoms, so that's not really my issue. Then maybe this isn't the treatment for you, and the benefits don't outweigh the potential risk. And
Hmm.
again, we overvalue risk when we have no idea how well somebody might respond to something. And
Right.
so I always say to people, give it 3 months, give it 6 months. If it's not working for you, fine. You need to talk to your doctor about other options.
And I think that one of the things that I'm also kind of hearing a little bit more subtly from you also is that we need to be making sure that women's stories are being listened to in terms of like how they are feeling. And it's beyond
Yes,
just the physical symptoms, but the emotional symptoms as well.
yes,
Like
yes,
I think sometimes for so long we've been like, you'll be fine. It's fine. It's part of aging. Get used to it. And I guess what I'm hearing you say is, I think what I'm hearing you say is also like the impact on my life. You kept saying like, what are her responsibilities? What are her impact?
yes,
What is her lived experience?
yes,
Let's just spend a couple minutes talking a little bit more about what you've
sure.
seen of where
Yes,
women struggle
yeah,
when it comes from mood and the emotional experience.
yes. Well, I think it's mixed together also, I find, with the cognitive experience too, because I did recently a national study, meaning I recruited women from all over the country, and it didn't matter where you lived in the country. I heard the same thing. I had an oophorectomy and went through a surgical menopause, and my brain is just not working the way it did, and I feel like I have adult onset ADHD. And my primary care doctor had no clue what to do for me, no clue at all. Now, we also, while I was doing this study, did another study where we just, asked women across the country, about their executive functioning symptoms and problems. And we definitely saw, if you compared perimenopausal to premenopausal women, and then surgically postmenopausal and naturally postmenopausal women, what you have found that is the highest complaints occurred in those who underwent a surgical menopause. But the perimenopause was right up there.
Interesting.
What you saw is a slight lowering back in the natural menopausal group. They didn't look exactly like the premenopausal women. They still had complaints, but they weren't as severe as what we saw in the perimenopause or with surgical postmenopause. And so we knew, and this kind of confirmed what I was thinking was happening with people undergoing a surgical menopause, is that they were having more of these symptoms than everybody else. And they needed to be looked at because we couldn't give them estrogen in the vast majority of situations. And so we basically tried an ADHD medication in a randomized placebo-controlled crossover design, meaning everybody had a chance to be on the medication, active medication, everybody had a chance to be on placebo. And we did see that within 3 weeks of being on the active medication, that they had an improvement, a reduction in their symptom severity. So there are other options when women can't use hormone therapy. But the other thing that we saw in the larger survey study is that if women complained of having depressed mood, anxiety symptoms at clinically meaningful levels, an attention deficit disorder diagnosis, so we control for that, and insomnia, basically those symptoms really contributed to some of the executive functioning complaints. Not all of them, but again, we still saw the perimenopausal women having more than the premenopause and the surgical menopause up here. But when you took into consideration people's depressive symptoms, their anxiety symptoms, their difficulty sleeping, you saw that even that, yes, the cognitive things were still there, but they were muted. So basically what this says is that if you've got all of these other symptoms going on, treat some of those things first. And you may find that some of your executive functioning complaints are not as problematic. They might still
Interesting.
be there, but they may not be as problematic. So sleep is a big one. So that's one of the reasons I target sleep a lot.
That's right.
Because
Right.
we know that cognition is really affected by sleep. Yeah.
Yeah.
And and if you're depressed and anxious, then that also is going to have an impact on how you experience your cognition. But with that said, there is still an executive functioning difficulty that I
Mm.
believe is above and beyond, particularly in people who've undergone a surgical menopause, is above and beyond even what depression can explain, anxiety, or sleep disruption.
And you're seeing it as executive functioning is the primary feature.
Yes.
And then we develop the depression, anxiety, and depression, anxiety, insomnia, or cognitive decline, or cognitive frustration. I guess you could say, whatever word you put in there, versus like you have depression, anxiety first, and that is resulting in some challenges in executive functioning.
I think that it can be either way. I
It
mean,
can.
it
Okay.
can. I mean,
Okay.
again, because when you control for sleep disruption, I mean, for example, let's just take sleep. Let's forget about menopause, whatever.
Yeah.
You
Yeah.
don't sleep. It takes multiple nights for you to actually have your cognition back to where it would be if
Yeah.
you had a good night's sleep.
Yeah.
So if you think about chronic insomnia, how its impact on your executive functioning is huge. Okay.
Sure.
So that has nothing to do with maybe depression. It has, whatever it might be. There may be lots of reasons why you're having insomnia. So I can't say depression causes the executive functioning issues. I can just say that in people who have complaints about executive functioning issues, if you look at the, and control statistically for the depression, for the anxiety, those symptoms are not as high and not as
Mm-hmm.
severe.
Mm-hmm. Mm-hmm.
So that's why we have to say it's important to, when somebody who's coming and saying, I can't think my way out of a shoebox, and I had an oophorectomy, I'm 45, I had an oophorectomy at 41, and I can't think of my way out of a shoebox since then. Obviously, you want to look at sleep. You want to make sure that you know, they are not in the midst of a depression, not in the midst of an anxiety problem. And then, treat the executive functioning issue because it is real. And I
Yeah.
think that that's one of the messages that I try to get out there is that these complaints are real. They're not being made up. It's not, oh, she just had ADHD and she just now realized it. No. I mean, this is the brain responding to this abrupt change in estradiol and your prefrontal cortex, which is really important. This, part of the brain that's really important for executive functioning. In some women is really being hampered. And
Mm-hmm.
part of that is possibly the loss of estrogen. Part of it is possibly genetics. There's a lot of reasons why this might be
Mm-hmm.
happening. But
And so
I
even if you
want,
don't have a surgical,
mhm,
a surgical intervention, a surgical
yeah,
oophorectomy, right,
yeah,
or an oophorectomy, you still are at risk for this being a possibility in your life
yeah,
as well. Just might
yeah,
not be as extreme. So in the
exactly.
last couple minutes that we
Sure.
have, what are some of, like, can we identify one or two misconceptions that you have, that people have in the world, around menopause that you'd like to correct?
Well, I think it's this one misconception that, you know, especially for women, whether you had an oophorectomy or not, that somehow, once you get through menopause, everything's supposed to be okay. For some women, it is. But, perimenopause can be really dramatic, and some women can have a quality of life change. And quite frankly, yearly, the annual budget or economic cost of menopause is $1.8 billion in the US alone due to loss of work productivity.
Wow. Wow.
So it's not nothing. And it's not all just about the mental health and brain symptoms. But the bottom line is that it's not nothing. It's not nothing for the woman, and it's not nothing economically. And again, women go through menopause when they're all a lot of times at the top of their professional game, or they're about to jump into that. They still have kids in high school, parents are getting older, and we're pushing the prefrontal cortex and expecting it to just function beautifully all the time. So I also say to people, give yourself a little bit of grace. Try to do things that help to settle down the brain and the stress system. I think that meditation, and if exercise is meditative for you, then great, you're hitting two birds with one stone. But we're multitasking constantly. And if there can be time during the day where you're not multitasking and you're just having a focused breath and, focused on the self and self-care. So it's not nothing. Menopause and some women experience these symptoms for over a decade. So it's not a small thing. And then the other thing is that I want people to just stop being so scared of hormone therapy and really get the information. And for people who it can be a benefit to, why live without it?
Right,
you
right,
know,
right, right.
like I said, we're living a third of our life in the postmenopausal state. If it's really beneficial to you, and then talk to your doctors. And if your doctors are one of the ones that are really, really anxious about it, the other misconception is that sometimes women feel like I can't leave the person I'm with because they deliver my kids. You know what? They might have been great when you were delivering your kids, but this may not be the doctor for you now.
Yeah.
So,
Oh, I love that. I love that. I love that. And this conversation, I mean, just is everything that I hoped it would be and
oh,
more. And
good.
I like, of course, I wish I could talk to you forever, but I'm going to be respectful of your hour. Dr. Epperson, this has been extraordinary. And
Well,
really
thank
thank you
you.
so much for sharing your wisdom with us and with the men and women that will be listening to this podcast. And
Good.
I know it
Good.
will help people. I know it will help people. So thank
Oh,
you
well, thank
until
you.
we
And
meet
thank you for
again.
giving me this opportunity to be with you
Truly,
and your listeners. I really
tr-
appreciate it. Thank you.
truly a gift.